Now the talk is open for discussion. If you have any question, please raise your hands so we can go in order. And I see many prominent hepatologists from around the world who have joined today. And maybe I can start with some of the prominent hepatologists who has done a lot of work in this field. Maybe with Dr. Singh, Dr. Sivram Singh. Welcome.
Hi. An excellent overview as usual by Younossi. He's done so much work and he's put together all the work he has done and the work done by others. But I believe there's a lot of gaps in our understanding of this problem, especially the role of microbiota. And I believe it's a bidirectional thing, the gut, the muscle, and the liver. So you have a three-way pathway going on, and how NAFLD affects the microbiota and how microbiota affects NAFLD. And this could be one of the reasons why you have the dichotomy that in Asians you have a different association between sarcopenia and NASH, which in that study which you showed there was no correlation with in the other population, because I believe you have much more dysfunctional gut microbiota in this part of the world, and that is why you have more of lean MASH and more of it is the phenotype of MASH as we see is quite different from that which we see in the West, where you have everything is insulin resistance is held responsible for everything, but that might not be true for all MASH. So this is something we need to look into. What's your take?
Yeah, no, thank you. Thanks for very important point you're making. I think you and I have talked about this, that the lean MASLD or the lean MASH being more common in Asia may be related to dysbiosis, related to other things, the environment, diet, and other things that's different. But as you know, lean NAFLD patients do have insulin resistance. So the majority of, and it's very complicated sort of situation where you go to large cities, say in China, if you go to large cities, then you will see, and even in India, you see the profile very similar to one that you see in the Western countries, because there is obesity, there is type 2 diabetes, and that drives the disease. But if you go to the rural area, that may not be the case. So you're making this very important point. Now, how much of this is really driven by gut dysbiosis? And I do believe that some of it is. And I think this is why this disease is not a single disease. I believe it's a phenotype. Now, majority of this phenotype is driven by having type 2 diabetes. Now, the question is, can these be slightly different from different regions of the world? I think it's influenced by a couple of things. One, of course, by genetic predisposition in different parts of the world. That would be one thing, and how genes are sort of driving this. And the other one is actually environment, not only diet, but the amount of ultra processed food, pollution, believe it or not, in different parts of the world can actually drive this. How that affects this disease in terms of liver disease or gut, it's really complicated, because as you know, diabetes changes the gut microbiome. When you develop more fibrosis, gut microbiome changes. So there is an incredible opportunity for people to start looking at this more carefully. The studies need to be done very, very carefully, because you don't want to mix apples and oranges and then get data that's not interpretable. That's part of the problem, is that if you combine patients that will that is mixed of, say, rural and large city sort of population, maybe you're looking at different sort of patients. When you look at large populations, then you get mixed of these kind of things. If you look at sort of more of a select cohorts, you may get this better. And I think ultimately this would be better to focus on, Shivram, as you suggested, to think about this disease as probably the best disease for personalized medicine, where you're looking at a patient and finding where is the abnormality. Is it in the gut? Is it in the, having too much visceral adipose tissue? Is it something else that's driving this disease in the patient? And develop treatment that is actually sort of targeted. So this would be really personalized medicine at its best.
Zobair, in sub-Saharan Africa, they have linked pesticide exposure to the type 2 diabetes mellitus. And pesticide exposure is a huge problem in this country also, and in South Asia also. You think that there might be some link between this NASH in non-obese people and pesticide exposure, especially in the rural countryside?
There's no doubt in my mind there is some association in Africa, in part of Asia, and even Latin America. There's a lot of that in there. The question is how to do these studies properly in a way that's clean, because it has a lot of implication, obviously, that would have important sort of policy sort of implications. So, but I think what is in the environment certainly impacts this disease. What it's actually in terms of pesticides, in terms of pollution, in terms of using using plastic bottles, for example, what leaches out of these bottles, where you're drinking water from the same bottle for a month, can actually induce obesity, type 2 diabetes, and also this disease. So that's really why this disease is so complicated, because there is a lot of environmental impact. There is a lot of sort of genetic impact we don't know, because some patients are now more predisposed to the disease. How to find this complexity, that's why it's a complex disease. The complexity to find this is going to be really decades to work on. We thought that we understand the epidemiology of disease, and we do have a sort of a global overall sort of approach to this disease. We can understand this, but when you come down to a single patient or a cohort of patients from one region of the world, I think our understanding is limited at the moment. We know some things, but we don't know a lot, and that would be a good place to start.
And last comment, what I see is that most of the presentations, including yours, on NAFLD management is focused more on the drugs. We talk less of lifestyle. We say that, well, you have to combine lifestyle, it is a cornerstone and all that. But we don't say that we don't stress upon the fact that these drugs come in only whether you have significant fibrosis or whatever. These drugs come into play only when lifestyle management fails, when you're unable to, for whatever reasons, just like ascites resistant or refractory ascites. So NAFLD or MASLD, which is refractory or resistant to lifestyle intervention, only then the question of no one talks of this.
Yeah, I think there are a couple of issues in there. One is that lifestyle has been so difficult to achieve an individual patient and maintain in the United States or in the West, for sure. Now, the problem, of course, is that lifestyle has not been properly actually prescribed. You don't tell a patient, go lose 10 pounds and come back in 6 months. That's not actually a recommendation of lifestyle. You have to make it available. You have to make the components of changing in lifestyle available. And then you have to really write a prescription and monitor like any kind of treatment for lifestyle. If you do it that way, it will be effective, and it should be for every patient. Now, so and that I think part of the problem. The second issue that you're alluding to is the fact that it's the lifestyle in the United States is related to so many other things that's just not diet. We published a paper that's actually in publication now in press in Journal of Hepatology, looking at both the United Nations data and also the GBD, looking at food insecurity and its association with MASH and its outcome. And actually, it depends on where you are. in terms of economics of the country. So if you're in high income countries, then actually the food insecurity is directly associated with MASLD. Food insecurity is associated with MASLD. If you're in the low income countries, it's actually starvation and lack of calorie that's associated. So understanding this at the global level is important, because then you have to develop region, country specific policies that will address those. And those policies that are developed for the US cannot be applied to India or Middle East. So you have to have that, and that information is important. The lifestyle is very important. People have given up on it because it's not as effective in some of these patients in the clinical work, but it's just because we have been doing it wrong for years. It doesn't mean that it doesn't work. When you look at data that when it's impacted, that is actually implemented well, it works very well, and it should be something we always do. You're right.
Thank you. May I invite Dr. Agrawal and then Dr. Kazi?
Sir, after hearing this, I think, the bottom line goes is that the diabetes is the biggest culprit, right? So when we used to study about the metabolic syndrome and other things, so this is the same thing which is coming up with different names in other places. And we need to control the bottom thing, which is increasing like anything all across the world, is diabetes. So if you control diabetes, in the whole talk, which I followed up of yours, sir, and so many other talks, it's almost around 72% to 80% people, who are diabetics develop their liver fibrosis, whether they are sarcopenic or non-sarcopenic.
Yeah, no, I agree with you for sure. It's diabetes and obesity that's actually pandemic in the world. The problem, of course, is that we don't have a magic solution to sort of deal with diabetes. But what I would at least recommend is that as we are dealing with other complications. So if you go and you're a diabetic patient right now, if you go to the clinic, they have no problem sending you to an eye exam to check you for retinopathy. They will do actually a GFR test or creatinine assessment for kidney complications, or you look for your diabetic neuropathy. But no one thinks about liver disease. The point I'm making is that you have diabetic patient, you should be doing actually a once a year screening test with a FIB4, the easiest thing to do, and then understand those patients are. But of course, in the best of the world is that if you manage the drivers of this disease, type 2 diabetes being the most important one, you will address not only MASH, but cardiovascular disease, retinopathy, and other things. But short of that, I think it's really important for our endocrinologists, diabetic sort of experts, are that they need to screen for this disease in the same enthusiasm that they do for retinopathy. I mean, then all of them actually do now. It's not an issue. The minute you mention liver disease, they just all look at you. I have to say that in the United States, our endocrinology colleagues have become much more sort of accepting of this. But in the primary care, it is extremely hard in primary care to get our primary care colleagues to pay attention to MASH. Well, this is no different than other complications of diabetes, and you need to screen for it, and that's what we're promoting. You're right, though. Diabetes is the mother of all of these diseases.
Mother of all.
Thank you, Dr. Kazi. Dr. Nadia Kazi.
Thanks. Hi, Dr. Younossi. It's so good to see you. Thanks, as usual, an excellent talk. So my question is not as profound as was asked by my other colleagues, but it's a little bit more practical. But I want to preface my question by saying I really appreciate the thought process that went behind changing the nomenclature, etc. But I'm increasingly finding it's it's a mouthful. And some patients actually feel a little insulted. They don't like it. They find it, I don't know, disrespectful, MASH and whatnot. So is there a way we can revert to the original? I'm sure the change in nomenclature threw a wrench into a lot of the research projects as well. The nomenclature had to be changed, etc. Is there a way we can address it and, revert, for lack of a better word, to the original nomenclature? I personally also don't like it.
Well, thanks, Nazia. Thanks. Great to see you in the Zoom. You know, it was a process. Dr. Singh and I and a number of people who are on the Zoom call who were a part of that. It was, you know, the best process that folks can do. I think, and you know, the term NAFLD came from Cleveland Clinic. When I was at Cleveland Clinic, came out of my team. So you know, it wasn't something that you know I wasn't familiar with. I think it did have shortcomings. But the two main sort of issue was that FATI itself was stigmatizing. Subsequent to that meeting with nomenclature, we published that it is stigmatizing, but it's for a small number of patients. But when it's actually much more, so 8% of patients feel that fatty liver is actually stigmatizing, 30-some% of the providers. So it's much more on the provider side that people think that fatty is actually stigmatizing. But it's actually most of the stigma was related to obesity. and the second issue, of course, had to do with the fact that it had to be connected to its metabolic sort of, you know, sort of underlying. Now, I've heard what you say, Nazir, from a number of my colleagues, that MASLD is much more difficult to talk to in a clinical setting with a patient. I think the only way we can do anything is to really how to refine this terminology in the future. I think this is not a static area as far as I'm concerned. Is that we will. I run the Global NASH Council. We did this study of stigma. We are going to do additional sort of studies in the future related to stigma and nomenclature appropriateness in the future. And I say that at this point, I think it is best not to you know, muddy the waters and create more confusion with people. So I have adopted the term MASLD, and I use MASH and MASLD all the time. But I do get your point that it is not the perfect term from a patient perspective. We hepatologists, you know, love to use words like steatosis or steatotic liver disease. For patients, that means absolutely nothing, and it's going to be important, and it's really important because of awareness issue. Because our biggest challenge is awareness. You talk about steatohepatitis or steatosis, half the patient don't even know what is steatosis mean. So I think there are issues we need to deal with, but at the moment, the world has come together. And I know there are issues with our colleagues from you know, some from India and from Apasal. There are colleagues, of course, that would not you know, accept the term MASLD. But I think at this point, it's just all of us need to come together and move the field forward, including reassessing nomenclature and time to see what we need to do. There are some advantages with this nomenclature and definition that has to do with MetALD, which is really a sort of a new entity where you have both metabolic abnormality and you also have alcohol consumption that is more than the threshold of what we call, you know, safe alcohol use or whatever thresholds you use. So there are advantages to the definition. But there are still some challenges, and we need to understand this better. I know Dr. Singh agrees with you. He and I spoke about this on multiple occasions. It's at this point, it's better to move the field forward and then see how we can define the nomenclature as we move forward.
Thank you very much.
Thank you. May I go to Dr. Younossi from Turkey? I think he was itching to ask some questions minutes ago. Dr. Younossi?
Yes, thank you very much. It was really excellent speak. Actually, you know, liver steatosis is very important problem for recent 40 years. And liver steatosis is becoming a prominent cause of the chronic liver diseases and also liver cirrhosis. But you know, there is a problem for the nomenclature because as a Apostle group, we realize that metabolic dysfunctions are very, very important for the liver steatosis. Now, 2020, Mohammed Islam just one paper appeared, and we said that metabolic dysfunctions associated liver steatosis, it means that we consider about the metabolic dysfunctions, but still in West, they believe that NAFLD, I mean non-alcoholic liver diseases, for the liver status is important. My question is there any consensus will be seen in the future for the nomenclature?
Well, I think the nomenclature, sort of development did include all societies, including some from MASLD. The issue of MAFLD, which is what you're referring to, of course, was the sort of concept. In fact, the connecting NAFLD with a terminology that would talk about metabolic abnormality came in 2002 in a single topic conference by the AASLD, for AASLD in Atlanta. I was there, was a part of that group, and it was not adopted at that point. But when MAFLD terminology came, there were three problems with that. One, that if you believe that fatty is stigmatizing, it was still kept in that terminology. So that was one of the concerns. And I'm just reviewing with you what the group decided at the end. So that was one. Second was that the cutoff for alcohol use for MAFLD was much more liberal. So if you look at the original definition of MAFLD, then you have a lot of patients who would qualify at either mid-ALD or alcoholic-associated liver disease will be in that group also. And the third problem with that nomenclature was that they would not have steatohepatitis as a category because it was all based on fibrosis. Now that makes sense, of course, but currently the drug approval process in the by the FDA or EMA is actually both steatohepatitis resolution and fibrosis improvement. So having said this, I'm absolutely a believer that the camps, that there are three camps. There are people who still believe that the terminology should be NAFLD or MAFLD or MASLD. They should continue to work together to come up with the best consensus. I've come to the conclusion that MASLD is a reasonable number. It's a reasonable name. And as Dr. Kazi just suggested, it may actually be not very accepted by the patients because it's more complicated. We'll have to see how it works, but I would really encourage our colleagues from MASLD to really put the differences aside. Let's come together and see how we can actually work together and make this better moving forward. I think we could do this. I agree. It's sometimes people get stuck in sort of the nomenclature stuff. This is really about understanding the disease as best as we can. We can call it whatever we want to call it. It doesn't matter. I mean, there's Wilson's disease. It really has nothing to do with copper. It has to do with a name of an individual and is being looked at the same way. So there may be some things that we can do. But right now, the effort, the national effort, the local efforts, the global effort is really to push the terminology of MASLD, what it's actually with the United Nations, whether it's with the World Health Organization sort of efforts, and I've been a part of few of these things. So it is going in that direction. And I think coming together as different societies should do is to come to a compromise and maybe make this in a sort of step-by-step approach of how to refine this in the future. But I'm a big believer in getting everyone together and making sure we all go in the same direction, because it doesn't benefit people when you're using different terminology and especially of different definitions, because that confuses the field, where we don't need confusion. We need everyone to be on the same page.
Thank you very much. I agree with you. Now, more than 100 authors now we gathered, and now we prepared the manuscript, and I think we are going to publish in Hepatology International very soon. Thank you very much.
Of course, thank you.
Thank you, Dr. Younossi. Those of you who don't know, Dr. Younossi was the former president of the MASLD as well. Now moving on to Dr. Dharmesh Kapoor. Dr. Kapoor, please.
Hi, Dr. Younossi. That was a wonderful talk, and we all know it's a lifetime of work and obviously very difficult to condense in 1 hour. Now, there are two questions I have. The first is your theme today was actually not so much MASLD as sarcopenia, as in the context of MASLD. Now, what are your thoughts on? I know it's not directly related to liver fibrosis, but what are your thoughts on losing muscle mass along with fat with the weight loss medication? So, how do you align in your clinical practice this kind of a phenomena which all of us see all the time?
Yeah, Dr. Kapoor, that's a very important point. Yeah, unfortunately, to give a talk on MASLD and sarcopenia alone for an hour would bore people, because then you have to go into incredible detail of things that have not been fully established. So it's important to put this in the context of other things, and especially what you're talking about, which is that the new drugs that are developed for weight loss can potentially reduce muscle bulk, and the question is, does it induce clinically relevant sarcopenia? And I think we need to monitor this. The only positive thing that I can tell you is that when you look at GLP-1 agonist receptor long-term data that came out of these cardiac sort of studies that has thousands and thousands of patients with long-term mortality, was improved by these drugs and not actually worsened by these drugs. Because if you really had a clinically important decline in muscle and causing significant sarcopenia by these drugs, you would have seen some at least negative impact on mortality. And I don't see that. But nevertheless, for our patients, I think if you're starting patients on a GLP-1 for weight loss, I think we need to monitor for development of sarcopenia. At least that's what I would do. But am I worried about it? To be honest with you, the benefit of improving diabetes and also improving weight, especially visceral adiposity in these patients, probably outweigh any impact on the muscle. But we have to understand this better, and that data for MASH patients is not out there. We don't know really how much is actually the muscle reduction, and is it really clinically relevant or not.
And the second thing which has always intrigued me is that we all talk about myosteatosis. So do we think in the context of, and now I am completely digressing from the theme of your talk, do you think that myosteatosis could actually be a protective phenomena as cirrhosis advances? Or do you think it is detrimental to the health of a cirrhotic?
Well, I think the grade of steatosis has really not been associated with outcome in patients with MASLD. It was stage of fibrosis, and for some studies it was the degree of inflammatory sort of component. So whether mild steatosis is protective or not, I haven't seen any data to suggest that. Even in the population-based data, we have looked at grade of steatosis and looking at outcome. It certainly was not protective. It wasn't also associated with mortality, with increased mortality. So at this point, I really only look at steatosis as a surrogate of metabolic abnormality that happens to occur in the liver, as well as in the heart, in the muscle with myosteatosis, and in a number of different sort of organs. But I haven't seen any data, Dr. Kapoor, that suggests that mild steatosis is protective. When I look at the data from the large databases that I've looked at and look at grade of steatosis, it was not associated with mortality either positively or negatively. None of these were.
Right. And lastly, I think it will be of great interest to this audience. So we all talk of the F2 and F3 fibrosis of this world, but what about the biggest challenge of the population at maximum risk, which is the cirrhotics? So you yourself considered that resmetirom is not a drug that we are going to use for the cirrhotics. So in your clinical practice, someone who's got MASLD related cirrhosis. So what would be your prescription of pharmacotherapy for a patient like this?
So I think you just have to look at what is it that we have in our armamentarium to manage things. So it depends on the cirrhosis. So if you have decompensated cirrhosis, there is really nothing you can do for those patients. I think if you have very advanced cirrhosis. In fact, the diabetes management of cirrhotics would need to be carefully assessed, because you don't want to use GLP-1 agonists or SGLT2s or other things in the cirrhotic population. You probably have to go back to, insulin to manage their diabetes. On the other hand, with well-compensated cirrhotics, the clinical trials currently doesn't have an option, because we don't have an option of what to do. However, if you have a well-compensated cirrhotic and you want to manage their diabetes and obesity, if they happen to have that, then there are effective treatment, both in terms of medical treatment that you can focus on, as well as even bariatric surgery. And the well-compensated cirrhotic, when I would say that well-compensated without evidence of portal hypertension, those actually get better. But it is in the United States, at least, it is not approved for treatment of MASH. So you have to treat it, you have to use it for diabetes or obesity. So the question also becomes, do we have drugs in the future that will be MASH targeted treatment for cirrhotics? There are a number of these, and what we have to do is to just wait. Unfortunately, these are very difficult studies to do, and it has to be the sort of target has to be an antifibrotic more than anything else. And so far, most of the antifibrotics have not worked, unfortunately. But there are trials right now.
Thank you, Dr. Kapoor, and then excellent points from Dr. Younossi as well. I wanted to just point out, going back to your myosteatosis question. So recently we were, in our institution, we're doing a study, 80 patients where we did the MRI PDFF at the L3 SMR level. And we're looking for myosteatosis, and we categorize patient into frail and non-frail and pre-frail based on the LFI measurement, liver frailty index. Interestingly, patients who are more frail, and they lost their PDF, they had less steatosis. Initially, before we did the study, we were actually thinking, okay, maybe the steatosis will actually cause more harm and they'll be more sarcopenic. But the study is not published yet, but we're still analyzing the data. But this is the preliminary information. Looks like patients more frail, they have less steatosis. I don't know your question. It is protective or not. That's something is interesting point that you made.
Yeah, I think the issue, of course, is to what are using frailty as a sort of a marker is appropriate, or should you use just a sarcopenia sort of a questionnaire and see if that actually will give you better data. I think that would be an important point. I actually think that sarcopenia could probably, the myosteatosis could play a part in some of the dysfunction that you see, but it won't be the whole story. You have to, because it probably creates the same sort of environment that it creates in the liver or in the heart or other areas. As you know, patients with MASLD have diastolic dysfunction, and that's probably has to do with myocardium and maybe some of the infiltration of the myocardial tissue with fat, in addition to the epicardium and all of that. So it probably will have the same milieu and the same damage to the muscle sort of environment. But it is also probably a indication of what's going on in the system, meaning in the pro-inflammatory sort of process that's going on. One indication of that is fat in the muscle. It could be high myostatin levels that could be correlated with this. So I would look at those things much more sort of in the context of sarcopenia than just frailty.
Thank you, Dr. Younossi. I think we are well over time. I don't know, Dr. Younossi has time, we also want to respect his time as well, but it's 9:30 and 9:37 in US. I know Dr. Jalal and Dr. Maliakal also want to ask some questions. I'm not sure, Dr. Younossi, you want to take that questions outside, or you want to take those questions now?
You can. I'm
Okay.
here
All
for
right.
as
So
long
with your
as you want me.
permission, Dr. Jalal, please.
Oh, thank you. No, that's a wonderful presentation, masterful, literally, covering everything, and that's what you expect from Dr. Younossi. That's a great talk. So, in the community practice, when you go, and that's where most of the MASLD patients are, risk stratification, all the guidelines start with FIB4 and then FibroScan. But majority of the places, they don't have FibroScan. And they're still relying on FibroSure, fatty liver, the test, something like that. And FIB4, literally, very young and very old, because this age is one of the factors, age dependent. I don't know whether, it has its own limitation, especially I know the data are out there, but if you look at even for Master NASH trial, where the FIB4 cutoffs were not, or the median FIB4 value was so low. So in the ideal world, I mean, we need a blood biomarker. And of course, in fatty liver patients, FibroScan could be very much operator dependent because a lot of patients are obese. So in ideal world, we should have a blood-based test. All these are based on MR-based or FibroScan-based. Do you feel there is more reason to evolve in this area? And I'm glad that we are having this ELF test now, which is available, but it's very expensive too. So what do you think for the future for this area? Should we expand more on FibroScan, which will not reach most of the people? I'm from Texas, Houston, and so most of the places that don't have FibroScan. Houston, yes, but the Texas is big. So what do you think the future in this area? And that's one question. The other one is a little bit, totally different area. So we don't do surveillance for fatty liver patients for HCC. And as you know, a lot of patients with MASLD develop HCC without cirrhosis. What is, because you're the expert, what is in your mind about
it's the test that we have in 2024 that we can use. It's easy to use and adopt in clinical practice, especially in the primary care and endocrinology setting. When you put it, it certainly has problem with extreme age. The cutoff may not even be appropriate for diabetics, but it is reasonable in general. The future probably has to do with two things. One, the transelastography and elastography sort of technologies are becoming much more competitive, the field is. There are a lot of new technology that's actually being developed, which is going to be much cheaper, easier to do, smaller, and can be used on the bedside. Just watch out for these in the next year or so. There's going to be lots of these. But the bottom line is that we need to have a better serum-based biomarker or something that will combine clinical data with some additional tests. And as you know, there are two consortia, one in Europe called Litmus and one in the United States called NIMBLE. These two consortium are focused to develop a biomarker that has to be easy, that has to be simple to understand, and has to be accessible to everyone and cheap. So I'm pretty convinced that we will have those in the future. But right now, this is what we have. And when I actually when I don't have a FibroScan, first of all, I refer a patient to one of the sites that's not close to if I get a call, I have three FibroScans in the office. But then my recommendation would be to recommend one of the sites that have them. if in the other, of course, scenario, alpha is available, but you're right, it's expensive. But you can write a prescription and get that. But the future is actually bright in this area, because I think you'll have much easier sort of approach with these small portable elastography technologies that are coming up. Now, the second question in terms of how to identify non-cirrhotic for risk of HCC. Currently, and in fact, I think some of the newer guidelines recommend this, is to look at the risk profile. And I mentioned this when I was talking about the HCC and the non-cirrhotics, which is really to look at patients' family history, if there is a family history of liver cancer. You look at presence of diabetes and individualize it. There are actually studies that are also looking at different SNPs, PNLP3 being the one that's commonly used, but they're actually sort of multi-SNP sort of profiles that are they're putting together to actually predict different outcomes. And some of these are sort of early stages. Hopefully, we will have a combination of clinical sort of factors and some of these SNPs that then you can individualize for a patient to risk. It's really not going to be screening. It's going to be where you can case identify patients who are at high risk, even if they don't have cirrhosis. So at the moment, I look at family history, maybe other things. If you happen to have a SNP of PNLP3, these are the patients that I actually then focus on and do individualized screening for those patients.
Excellent. Thank you.
Thank you. Dr. Maliakal, final question.
Thank you very much. I have several questions, but I think there's not much time left. I think the whole world is indebted to Dr. Younossi for all his work in this area. I think we know so much more about fatty liver disease or steatotic liver disease from all work he has done. I think one of the problems in managing patients is that nobody manages comprehensively. Primary care refers to cardiology or hepatology. Hepatology doesn't have time. So what I find is, unless somebody takes full control of the patient and manages from a primary care standpoint and addresses all the issues, the patients don't get served right, because they get kicked around, especially with advanced fibrosis, etc. As hepatologist, I try to manage, but I can only manage a few patients. I kind of take over, and it seems to work very well. Second thing, in terms of sarcopenia, I wanted to say is, the old adage, fat but fit versus lean and unfit, seems to be realized in this kind of situation, where lean NASH, if they're lean and unfit because of frailty or whatever, they don't exercise, they have the worst prognosis. But in the West, there are more fat and fit patients, and more in India, for example, there are probably a lot of lean and unfit diabetic kind of patients, and therefore you can see the cardiovascular and overall mortality is higher. And the third thing is, resmetirom does work on the liver, but it doesn't change the weight. And it would be very interesting to compare, say, GLP-1 versus resmetirom in terms of overall mortality and sarcopenia, etc., because it'll be kind of very, very interesting to look at, or whether the combination is better than each one. I think I'll leave there.
That's a great points, and I'll just address all three of them. One, I think, had to do with how to manage these patients. I think this is not a patient that you can actually. These patients are not the kind of patients that you just focus on a single disease. There are now clinics, multidisciplinary clinics, that are coming together. The question is, how do you actually create these clinics where you're addressing the metabolic sort of abnormality in the context of not only a hepatologist or gastroenterologist, but also a endocrinologist or diabetes expert, as well as sometimes behavioral health expert, nutrition, and exercise. The challenge is that there are actually physical sort of multidisciplinary clinics that are being actually developed, and they work very, very well. We have one. The challenge is that in the United States, a health system will have to support that, because the payer sort of approach in the United States wouldn't allow for, say, coverage for behavioral health or coverage for exercise specialists. So the system has to cover that, and that should be around pay for performance or outcome-based sort of payment. You can also create this virtually, the model that we used to use for hepatitis C treatment called ECHO. You can create that. But I think that will be the ultimate goal, is to develop these multidisciplinary teams that will take care of these patients. So that's one that's important to do. In terms of the resmetirom, now remember, resmetirom also improves lipid profile, so there may be some cardiac benefit over time, but it certainly does not affect, doesn't have any impact on obesity or type 2 diabetes in that context. And yes, I think we should have long-term data to see what drugs are better. Right now, that's the drug that we have, and for those who qualify, I use them all the time. But I think at some point we will have to have combination of multiple drugs. I actually believe that you have to have drugs that target liver, and resmetirom is the first one in that category. They will have more, and then drugs that will target metabolic risks like GLP-1s and others. I think ultimately you'll have a combination of drugs to use, and then you will have to probably treat these patients for a period of time with combination, and then keep them on a maintenance of one drug or so that is tolerable, and you can use it for the future. I forgot your second point, but these are the two comments I have for you.
Yeah, the question of fat and fit versus.
Oh yeah. I think you're absolutely right. I think the some of those sort of categorizations should come back, and especially in the context of sarcopenia, we should look at those individuals who were included in the Asian sort of meta-analysis, where it was associated with higher rates of even adverse outcome. These are the lean, unfit patients, and see if that's actually. I think it's going to be an interesting study to do. Absolutely.
And one last point, we talked briefly about DEXA. I guess DEXA, we're talking about osteopenia, osteoporosis as a correlation to sarcopenia, and not a muscle-related DEXA.
Oh no, you can actually measure muscle. You can actually measure muscle. There is actually a specific sort of component of looking at skeletal muscles and the components. So DEXA in that context is for muscle measurement, not for bone measurement. But
there have been studies which have shown that DEXA correlates with sarcopenia also in cirrhosis.
Of course. DEXA is associated with sarcopenia. It's a way to measure muscle in whether you're in cirrhotic. The cirrhotics are different in terms of their sarcopenia. Their muscle loss is very different than what we're talking about here, which is obese sarcopenic. And when you get to the cirrhotic sort of MASH patient, then you have probably a combination of multiple things that's actually going on, and that of course is different. Yeah.
Thank you,
Dr. Younossi. Thank you so much. This is wonderful discussions, great talk, and we're truly honored to have you in our forum and enlightening us with such a variety of things that you spoke today from A to Z in the field of NAFLD in such a comprehensive, in a 1 hour time. Thank you again for coming in, and with your permission, we can put it in our website so those who had missed the lecture, they can listen to this talk. Again, thank you, the whole audience. I would like to thank you for participating in an engaging discussion, and keep coming. Every 2 weeks we'll be having some beautiful talks like this, wonderful talks like this, and we'll continue to do our best to educate the world. Thank you so much.
Thank you, Sanjay. It's been a pleasure and an honor to be a part of this program, and thanks for organizing this. Thank you.
Thank you.
Thank you.
Bye-bye.